Assalamualaikum and a very good morning to everyone who are joining us online on Breakfast at FOM live webinar series, episode 18. I'm from Marzida and I'll be the moderator for half of today's sessions. I'm from the Department of Anaesthesiology. We have about 40 attendees now, and thank you for joining us this morning. Before I start introducing our first speaker today, I just would like to remind all attendees that if you have any question for the speakers, can you please use the Q&A box. It is my pleasure now to introduce our first speaker today. It is Dr. Lim Siu Min. He's a clinical specialist and also a senior medical lecturer in the Department of Anaesthesiology. He has great interest in regional anesthesia and pain medicine. And in our department, he's the person that we will look for whenever we have problems, especially with ultrasound-guided regional anesthesia. And he has been putting his a lot of time teaching and also conducting workshops, especially for the master's student, to spread the new technique in peripheral nerve blocks in our department. He also has done a lot of research on acute pain and also chronic pain clinic in our department. Please welcome Dr. Lim Siu Min, who will be talking on regional anesthesia and pain medicine, the beginning of a journey. Dr. Lim.
Thank you, Prof. Marzida, for the kind introductions. Good morning, everyone. I'm Dr. Lim Siu Min from the Department of Anaesthesia, and today I'm not going to talk about a study, a paper, or some new knowledge, but I'm going to share with you the journey of how our department improved the regional anesthesia and pain medicine service by the organized team effort. There was more than 300 million of operations was done globally in year 2012, and in Malaysia alone, there is 1.1 million surgery done in the Ministry of Health facility alone in the 2016. And guess what is the common things among all the patients undergoes of surgery? Yes, it is pain. Almost all surgery cause some sort of pain. And the principle of the peri-operative pain management is multimodal analgesia, where we use 2 or more different classes of drugs that act on the different pathway of the pain pathway to reduce the patient's pain. And in moderate to severe post-operative pain, the most commonly used drugs will be strong opiates such as morphine or fentanyl. It is very effective, but with a lot of side effects as well. However, with the increasing popularity of the Enhanced Recovery Other Surgery or ERAS program, and also opiate crisis in the America, people start to look for alternative to the opiates. And that's when the regional anesthesia comes into play. And what is a regional anesthesia? So basically, regional anesthesia is when local anesthetic medications are injected in or near the spinal canal or near a bundle of nerves to numb only the area of your body that requires the surgery. So it can be divided into 2 broad categories. One is a neuroaxial block, and the other one is a peripheral nerve blocks. Example of neuroaxial block include spinal, epidural, combined spinal and epidural, or continuous spinal anesthesia. And usually we numb lower half of your body for the surgery, such as cesarean sections. And the example of peripheral nerve block include brachioplexus block, femoral and sciatic nerve block, and others nerve block, where we numb one limb or one arm for the surgery to be performed. In RAPM, we focus on peripheral nerve blocks to provide analgesia or sometimes anesthesia to the suitable patients for their surgery. So why regional anesthesia? Because it provides excellent analgesia effect. It's really easy to perform once you acquire the skill, and it produces consistent result in experienced hands. It also have very long duration of analgesic effect, whereby a single injection can last up to even 24 hours after surgery, and we can even make the duration of the analgesia effect longer by inserting a catheter and run some drug infusions. And it has less systemic side effect compared to opiates. For all these reasons, regional anesthesia is widely practiced for peri-operative pain management globally. Just look at our own statistics from UMMC in the year of 2016-2018. I exclude obstetrics because it has very specific type of anesthesia. So we run about 8,000 to 12,000 of cases each year over these few years. And you can see that majority or about 80% of the surgery is done under general anesthesia. Regional anesthesia, which is under the blocks, account for less than 5% of the surgery done. So about 200 to 400 cases per year, the surgery was done under purely blocks. This block was not done for the anesthesia effect usually. They are done for anesthesia because this group of patients are high risk, and such as those with the ischemic heart disease, where we use peripheral blocks because of its superior hemodynamic stability. So when you look at regional block as a peri-operative pain management, we try to look at the acute pain service record in the similar years. We follow about 10% of the patient after surgery because of manpower issues. We don't have enough nurses and to follow all the patients, which happen in most of the hospital. The majority of patients actually receive a PCA, or the patient control analgesia, which is usually morphine or fentanyl, the strong opiates again. And very little patients receive regional block as their mean of pain relief. You can notice also the number of the patients followed after regional block was much smaller compared to the number of surgery done under regional anesthesia. And we do not follow all the patients. And from this data, you can conclude that the RAPM is not being widely practiced in UMMC at these years. So we try to figure out why RAPM is not being practiced in UMMC. So there is a few things that we found out. We realized that most of the medical officer either have inadequate sonor anatomy knowledge or unable to apply the knowledge into clinical practice. They usually have limited experience or exposure in regional anesthesia. Most of them have poor hand-eye ultrasound image coordinations and need a lot of practice and supervision. Also, we don't have a dedicated medical officer or regional team to perform the regional blocks. There is no proper supervision, and not all anesthetists are proficient in doing all the blocks. Sometimes the MO is busy in the OT attending to ill patients, and they don't have any time to perform the blocks. And peripheral block takes time to do, more so if you've done it rarely, and this can potentially delay the OT time if not managed well. Also, there is a limited number of ultrasound machines available in the OT, where they are shared among all the OTs using for vascular access and others. So sometimes we have to wait for our turns to use the ultrasound machine. We also have to use a special block needles for the procedure, and it runs out of stock on and off. And finally, there is no proper guideline or protocol in our local setting in UMMC for the medical officer to refer to when they have doubts. Overall, I can say that the OT environment is not very conducive of the RAPM practice in UMMC. After identifying all the problems, in year 2018, a group of enthusiastic regional anesthesiologists, including Associate Prof. Shanas, Dr. Michael Bay, Dr. Ling Woon Lai, and myself, we decided to work as a team with the aim to try to improve our RAPM service in an organized way. We started in year 2018, and we were so determined. We even designed our own logo, and we come up with the banner as well. So we did quite a few things. First is to improve the skill and knowledge of the medical officer regarding the regional blocks. So we organize regular ultrasound guided regional anesthesia category workshop in conjunction with the Salamander program. It is a 2 full day course where we have a theory sessions, we have a demo on the healthy volunteer sessions, and then we have the category sessions during the we organized 6 workshops. We did 3 workshops in 2018, 2 workshops in 2019, but only 1 workshop in 2020 due to the COVID situations. I want to take this opportunity to thank the Salamander program, which our participants feedback that they learned tremendously during the category sessions. Our team also helped the SIGRA Malaysia to successfully organize a pre-Congress regional workshop during the World Congress of SIVA TCI in year 2018, where candidates come from all over the world to join the workshops. In terms of protocol and guidelines, we developed our own comprehensive guidelines for the RAPM service. Medical officers are now required to complete 1 month durations of the RAPM posting, where they can do the regional blocks continuously within that 1 month without having other OT duty at the same time, so they can really focus on the regional blocks. It is very important for them to practice and consolidate the knowledge and skill that they have learned from the workshops. In year 2018 as well, I think our main OT was renovated. We took the opportunity to actually create a 2-bedded regional corner in the operation theatre. This is a dedicated place for parking of the ultrasound machines and other equipments needed for the regional blocks, the medications used for the blocks, the monitoring systems where at the place where we perform the blocks. The aim is to create a conducive environment and to centralize all the resources for performing the blocks, also for teaching and supervision to be done easily. This setup also helped to reduce our procedural time and thus prevent the delaying in the OT time. We also proactively offer RAPM service to the potential patients coming for surgery and develop our own booklets in 3 different languages for the patient to read and understand what is a regional anesthesia. You can see that on the cover of this booklet is pictures of our very own GA nurse who actually had uncontrolled severe pain after an ACL tendon repair. Even he was put on a PCA morphine. He then received a rescue femoral nerve block and basically pain-free after that. He's very satisfied and willing to share his experience of the peripheral nerve block with the others, and that's why we put his pictures here. As we are in the setting of the academic center, we also try to incorporate research into our RAPM service. We have articles published in international journal and poster presented in local and international conferences. Our team also managed to secure a research grant with the breast team to embark on the ERAS protocol to improve patient outcomes. And all the data of our patient undergoes of regional blocks. The information will be keyed into a RAPM system for future audit and also research activity. However, our journey is not a bed of roses. We do face quite a bit of obstacles along the journey. Manpower is always one of the main issues, as it is not all the anesthesiologists are proficient in all regional blocks. A few of us had to take turns to be in charge of the RAPM on top of our normal busy schedules. We even had to come back on our off day sometimes to do some specific nerve blocks. We do face resistance initially when we just started from surgeons and our own colleagues as well, worried that the regional block will delay the OT time and we could not finish the surgery on time for the day. So what we do, we call patient early, we perform the block at the regional corner with all the equipment and the medication ready to minimize the procedural time. We also modified our regional techniques to minimize the model block in those patients with surgeon wants a patient to have an early physiotherapy after the surgery. So over time, our colleagues and surgeons realized the benefit of the RAPM and they started to request for it. So that shows that it's actually beneficial. We also have complications when we do all the blocks. We have some block failure, we have peripheral nerve injury, we have local toxicity, and we have pneumothorax or phantom nerve palsy. But we manage all this. We manage to handle all these complications well. For the equipment parts, we work closely with the nurses and company representative to make sure the adequate stock for the regional needle and also medications. We still run out of stock sometimes on and off. Sometimes there's delay in the purchase order. Sometimes there is a delay in the stock handle delivery from the company side. So we have to become a middleman and try to settle the problems. We do expect to face some resistance from the medical officer, as regional nerve block might not be the cup of tea for everyone, but surprisingly, most of them enjoy RAPM posting and even good interest into it. So here we are, 3 years after we embarked on our RAPM journey. From the FPS record in year 2018 and to 2020, we surely see a surge in the regional nerve blocks we perform for peri-operative pain management. In 2018, we had a total of 577 cases. That is when we just started. 2019, the number grew to 995. And in 2020, the number is smaller because of the COVID, that less surgery is performed and it's an incomplete data year. Now about 20% of the patients receive review by the FPS team after their surgery. You can see the number grew, and up to 40% of this patient actually receive RAPM service, especially in the year 2019. And from the RAPM system, we look at our data from in the 2 years period from the 1st of June 2018 to 31st May 2020, we actually have done 2,411 blocks in 1,770 patients, because some patients receive more than one block for their pain relief. 60% of this block are performed for anesthesia, and the other 40% actually performed for surgical anesthesia. And you can see that majority of this block, about 85% of them, are performed by medical officer under supervision. And the most direct measurements of the success of this block is actually the PAN score, which is actually extremely low at the recovery area immediately post-operations and at the ward post of day one. You can see from the PAN score at rest and also a PAN score in the ward here. It's very, very low. And most of the patients reported that they were either satisfied or very satisfied with our RAPM service. In the end, what matters the most is when you have a satisfied patient and you watch a smile on their face with minimal pain after the surgery. I would like to end my talk with a quote by the Guillaume Labors. Every accomplishment starts with the decision to try. And I'm happy that we made the decision to try to improve our RAPM service 3 years ago. With that, thank you for spending your time with me this morning.
Thank you very much, Dr. Lim Siu Min, for that very interesting talk. And congratulations for Dr. Lim Siu Min and his team for setting up the RAPM service in UMMC. We have one question for Dr. Lim from the audience. It's from Dr. Terence Ong, and he's asking, peripheral nerve blocks are part of international hip fracture guidelines, however, underutilized in PPUM. Will it be something the RA pain team be interested to see how it can be embedded into our routine practice?
Okay. Can you hear me?
Yes, yes.
Okay, for the regional block in the hip fractures, that I think what happened is that usually the it takes time for the emergency department to be admitted to the ward, and the regional anesthesia service for the hip fracture should be started in the ED itself. And ideally, a catheter should be inserted for the pain relief from the starting of the hip fracture and also continuously until post-operatively. However, I think in Malaysia itself, we had some problem with the supply of the catheter set. And the UMMC, we usually modify using epidural catheter. I'm sure in the future, we will try to expand our service to this kind of patient as well, when we can get hold to the catheter set. But that will also means that we will increase further our workload when we start to do regional block in the emergency department itself.
Thank you very much, Dr. Siu Min. We've got another question here from Dr. Nur Azim. He said it's an excellent talk. So he's asking, how do we as an institution handle situation where patients who are on anticoagulants or double antiplatelet therapies will benefit from regional blocks? Do we have a protocol for everyone, including relevant departments like surgery and cardiology?
Okay, we do not have our own protocol regarding the patient on double antiplatelet or any anticoagulation agents for regional block, but we do have very established international guidelines that we can refer to. One of them will be the ISRA guideline for anticoagulations, ISRA-ASRA. So we always look up to that. And the principle is quite simple. We should treat them like a neuroaxial block, central neuroaxial block. Any contraindication to do the blocks for central neuroaxial blocks will be a contraindicator to all the deep peripheral blocks near neuroaxial. So, for example, the QL blocks, those lumbar plexus blocks, they are very near and very deep blocks. So those blocks shouldn't be done in patient on double antiplatelet. Otherwise, in other parts, for example, femoral block or sciatic blocks, they are quite superficial. And those blocks are actually, we can do on the those patients with double antiplatelet, and we have done quite a lot of them. And so far, we do not have any issue with the bleeding. Okay, and it's under direct ultrasound guidance, so we try to avoid all the vascular structures. And if there's a small hematoma or there's bleeding, usually easily compressible, and the bleeding will stop by the compressions usually.
Thank you, Dr. Siu Min. There's another question from Prof. YK Chan asking, do patients have to pay for the needles?
So far, I think they build into the system. So I think UMCs have to charge them as well. So I think it's in the system. They don't have to buy the needle on their own, but they'll be built into their hospital bill.
Thank you. Perhaps I have one question for you, Dr. Siu Min. There are so many peripheral nerve blocks that can be done. Which of these peripheral nerve blocks do you think will have a very bright future in terms of improving patients' outcome?
I think the peripheral blocks that benefit patient the most will be the peripheral block being done on the patients. Okay, so those simple blocks is the one that are actually most effective and most beneficial, because it can be done by most of the people. If you have a very good block, but very few people can perform it, it will not benefit a lot of people. So peripheral blocks like femoral blocks, like brachial plexus block, which has one of the entry-level blocks that we teach all our students and let them do under supervisions. And these are the blocks that they can actually use it for most of the patients. So I think that will be the two blocks that I will recommend.
Yeah, we have a little bit more time. Someone in the audience, Justin Wang, asking, thanks for a great talk. Just wondering about acupuncture and any potential for that in the next few years.
Actually, myself, I don't have any experience in acupuncture. but we do have some great papers talking about the great beneficial of the acupuncture. And I think someone is doing the acupuncture in the psychiatric department for some relief and for anxiety and other things. So I do think that there is a potential for using acupuncture, but is you have to select the patient very carefully. So not everyone will respond very well to acupuncture. So regional block is produce very consistent results. So I would say that there is potential, but it will take a while to bring it into the main practice.
There's another comment here from Sham Amir congratulating you for establishing the service. It's definitely safe for some. Maybe for the audience out there that's not so familiar with peripheral nerve blocks, right? Can maybe you could tell them how long will the blocks last after single injection?
Okay, so the block last usually depends on the medication that we use. So we usually use ropivacaine 0.375% for anesthesia, and for anesthesia we use 0.5 to 0.75% of ropivacaine, or 0.25% of levobupropion for anesthesia, and anesthesia we use 0.5% of levobupropion. So usually the block lasts anything between 12 to 24 hours. With an average of about 18 hours on our audits. Okay, so some of the patients are high risk for have a prolonged motor block or sensory block. Those patients with diabetes, with some peripheral neuropathy, so they tend to last a bit longer. So I would say safely around 18 hours will be the mean or average that the regional block will last.
There's another question here from Prof. Vaiki Chan again. How do the medical officers get to be passed as independent provider of the block? Do they need to have done it 60 times to be competent?
I think so far we don't have any credential of privileging for them to perform the blocks, because I think the society's SIG already decided that maybe we should not implement this CMP, which will actually become obstacles to more people performing regional blocks. So we want to encourage people to do regional block and not restricting only after fulfill certain criteria you can do the nerve blocks. And on the other hand, we also want to make sure that those medical officers who are performing blocks have some adequate knowledge and skills. That's the reason why we actually organize this cadaveric regional nerve workshop, where the student can actually perform the blocks on the cadaver rather than the real patients, and to improve their skill until they are proficient enough, and then they will perform the blocks under the supervision to minimize the complications. Yeah.
Dr. Sham Amir asking whether is it safe to do some of the peripheral nerve blocks without ultrasound, such as wrist block, ankle block, and popliteal nerve block.
Of course, actually, when the ultrasound regional before the era of the ultrasound, regional block is mainly done under what we call a landmark technique with a nerve simulator. Okay, so it has been demonstrated it's quite safe. However, the success rate is not as high as the one that is done under ultrasound guided. So when you have ultrasound, you can actually deposit the locker more precisely nearer to the nerve to avoid complications such as vascular puncture, and also to reduce the dose that we use. Okay, so if you want to do blindly under the landmark technique, is still produce quite good result, but then you'll be inferior to the ultrasound guided regional blocks.
Finally, Dr. Terence Ong asking, if you put in a perineural catheter, how long can it stay in?
From our own experience, the catheter can stay around 5 days to a week or even longer. We basically check the catheter every day to make sure there is no inflammation or infections going on. And if it's clean, then we can keep it longer. So usually our center we keep it 5 days to 1 week for those patients who are having a fracture but unable to undergo a surgery for their pain relief. And we usually remove that after 1 week, or sometimes until the time they have the surgery, then we remove it after the surgery. Okay, so the risk of the infection is not very high. So far, we didn't have any cases of catheter infections. Okay, more commonly it will be dislodgement of the catheter during the dressing handling of the catheter, or the leaking from the side of the catheter. We don't have any case of infections.
Thank you very much, Dr. Lim Siu Min, for your presentation and for answering all our questions. I think it's time for me to pass over the session to the next team from sports medicine.
Thank you.